behalf of Region 7 and the Ask for Respect Supplemental Grant, we want to welcome you to our series of interviews focusing on the perils and pearls of lessons learned regarding COVID-19. Our hope is to share the lessons our colleagues have learned and to assist you with your healthcare journey during this pandemic. Thank you for listening.
I'm just going to ask you to just tell us a little bit about yourself.
I started out life as a small town family doctor. I came back to teach at a residency program, really got a passion for public health and policy. So went back and got my master's in public health mid-career. And then when I did that, had multiple grants come up at the same time. And I was going to do one half-time while staying in the faculty, and two came up. And so I left and did both. And so I've had, the last 11 years, I've split my time between community, nonprofit, public health, and health system work. And then some of that nonprofit public health work got me into the schools around fitness and academic achievement, which got me more and more involved in the schools. And then eventually they said, would you please run for the school board? We need you to fill a seat. And so I'm also on the school board now. And it just so happens that, well, having an MD with an MPH on the school board in the pandemic is kind of handy.
Yeah, right.
And then, and interesting, the way the YouTubes I do came up because all three groups were asking me the same kinds of questions. Clinics were asking me questions. The nonprofits I worked with were asking questions. The school boards and school leadership people were asking me the same kinds of questions. Said, well, rather than say it, I'll just record the explanation as a YouTube. And I started doing these 10 and 12 minute updates. And that's where that really just took off. And then I just put it on Facebook one time just to see, and lo and behold, people started watching the heck out of it. So I went the first one and there was like 300 views. Next morning was 600 views. Like, well, okay. So I started adding some like, what can you do as an individual stuff at the end of them? And I'm on episode number 54, come out tomorrow. So we'll see.
Yeah, they're really good. I did listen to one today, and I'm going to become one of your followers now, just to hear all your information. Okay, so what we want to do today really is talk about infection and infection control, and what can we do to prevent the spread of COVID. And one of the really neat tools that the CDC has given us is the chain of infection, where it really does show you that infection really begins with the introduction of a pathogen. And I've just wondered, would you mind maybe talking through what the chain of infection and maybe highlight the opportunities that we have to stop an infection occurring?
Yeah, well, I think two concepts. One is doing your best to understand the concept of exponential spread, which is totally not intuitive. So you almost have to draw pictures of it. But when it goes from 1 to 2 to 4 to 8, it can grow crazy fast. And understanding that any little thing early on can make a huge difference later on. And that's why understanding the potential to grow really fast. But then the other concept is the fact that most of our interventions aren't perfect. They're maybe 70%, 85%. And so one intervention by itself is not good enough. And so you start adding layers. And the Swiss cheese analogy, I think, tends to work the best. Everybody can picture Swiss cheese having holes. And they put the sandwich on the cheese and they figure, oh, wow, if I put 3, then I see no more, ham showing through. And then our infection control practices are very much like that. And so, probably one of the biggest things that had a lot of controversy out early on was the mask or not wear a mask. Part of the problem with the controversy is people were looking at only from one end. They're only looking at the receiving end, meaning, does it protect me? And they were comparing it to an N95 mask and what you might do in an Ebola ward. And is it 100% effective? No, it's not. It's only partially. But what they really started thinking, well, about the sending end, that the person who's infected, if they're wearing masks, and that's where it made a huge difference. And so I think it's a while for them to think of infection control a little differently. And I struggled with one of my surgery colleagues because he was all about, if you break sterile field, you're done. And it's like, well, that's not what we're talking about. We're talking about a public health numbers game. We're not talking about the infection of that patient under your knife right now. And it's a different concept. And so even physicians had a hard time with it because they were looking at it, the individual patient and surgery concept, not the public health numbers game perspective, which is more public health. And so I think those are a couple examples of it. You had to think of it differently.
Yeah. The whole masking, we've got some people that just absolutely believe it and they're doing the right thing. They're wearing their masks, they're wearing them properly. And then we've got so many others. And I think you're right, that the mask is really, I'm wearing it to protect you. And, I tell my family and my friends, if you were having surgery, would you be okay if your surgeon didn't have a mask on? It's that concept that it's the wearer that we're blocking. And so The other really great thing about masks that I read this week was our CEO, Dr. James Linder. He actually put a social media thing out this week, and it said COVID doesn't survive very well outside the body. So if you wear a mask, you're going to keep it in. You're not going to spread it, and we could deal with this really easy, but only if we could get people to just wear a mask and also wear it properly. I heard a term on one of your YouTube talks about nose commando.
Mhm.
Do you want to explain that?
Yeah, well, surprising to a lot of people is the nose is actually connected to your lungs. The mask isn't covering your nose. Guess what? It's still coming out. So it just literally doesn't work if it's not covering your nose. And it drives me crazy because you see it so often. It might be a politician. It might be that person over in the, bar. It's like, it's got to cover the whole nose. It's hard, and especially in a school environment, because they don't have a big nose like me, those little kids. So it falls, of course, there's but it has to cover both your nose and your mouth because we breathe out of both, literally. So just getting people to understand that for it to work, you got to do it right. So if you're not doing it, of course, it doesn't work.
Right, you're right. If we go back to the chain of infection, you've got the pathogen, you've got its reservoir, and then you've got it's got to have a portal of exit, right? And so if you block that exit, then it's not going to go anywhere. So now you've cut that chain, or you've broken that chain, and it's not going to happen any further. So anything else though that we should be doing other than wearing a mask?
Well, that's probably the number one. And the other one is distance. And that caused just as much controversy because people got obsessed with the 6 feet, and 6 feet is not a magic number. And it changes based on conditions. And so that historically came back from spread. I believe it was meningitis outbreaks in schools where they found most of the kids who spread to were within 3 feet of the other kids. And then there was a few that were up to 6 feet. And so they made that's where the 6 feet came from. And then they also did some studies starting way back, I think it was Navy recruits, where they literally had them talk and then had Petri dishes on the floor at 1, 2, and a big drop off after 3 and especially after 6. But then people got too obsessed with 6 feet and realized that, in the school setting, those are kids sitting there quietly. That's not the same as yelling, cheering, singing, whatever, or especially like in a fitness center, for example. And people got out their tape measures and said, well, the fitness, the elliptical trainers are 6 feet apart. It's magically safe. No. Well, actually, no, you breathe. How far it goes depends on how hard you're breathing. And a sneeze could throw it out 20 feet potentially. And so people need to have not this black or white way of thinking that 5.9 feet is bad and 6.1 feet is good.
Right.
It's the gradation, and it's going to be affected by your situation.
And maybe even like airflow in the room, like a fan. If you're sitting under a ceiling fan, it's going to spread further.
Yeah, and airflow can go 2 ways. And so, like, for example, some of those outbreaks, there was a famous epidemiology where they even had the visuals of who got infected, didn't. It was partly the airflow of the room. So without any wind, it might go 3 to 6 feet, but with this thing blowing around, that you could actually see how it spread to the table over and then circulated around the room and came back and got the one on the other side, actually. And so it became sort of a vortex type thing. And so how it was ventilated made a big difference. On the flip side, if you had well-designed ventilation systems, that actually could decrease the spread. And so that became a big issue even in Lincoln Public Schools, because we finished a bunch of indoor air quality projects, which sounds totally boring and kind of is in some ways. That was a huge from a timing span. We literally had completed them all last year. So all of our rooms have 3 air changes an hour. And the evolution of thinking, initially people thought it was almost all droplet spread with maybe a lot of fomites. So and some people went a little overboard with the hand cleaning, I think. But there probably is some aerosol spread, especially when you're there in the same room for 30 or 60 or 120 minutes, for example. So we had those air changes, and that made at least our school system safe, but maybe not another school system who didn't do their air quality projects. And so ventilation is proving to be a bigger issue than people thought through as well.
Yeah. I've been doing a lot of work in nursing homes and going in there. And unfortunately, there's some nursing homes that have got really old ventilation systems. Others have got, nice new ones. One of the things that we are noticing too, though, is that you can almost create a really good environment if you've got a room with a resident who's got COVID, keep their main door closed. But if they've got a toilet with a fan in there, keep that running and keep that door open. And that kind of like pulls everything that way.
Kind of the poor man's negative pressure room.
Right, right. Yeah, it's amazing how little things like that can really help. Yeah.
Yeah,
Um,
we have a unique situation. Actually, the room I'm in right now, my nonprofit's located in what used to be a hospital 40, 50 years ago. We've been complaining for years about the windows being so bad because you can feel the air moving through them. Well, it turned out that it was good that they didn't replace the windows because our ventilators are horrible. So at least so that's actually been a good thing.
so a little bit of
Old
ventilation
rehab
for you.
hospital. So
Mhm.
sometimes it's better to
Nice.
be lucky than good, like they say sometimes,
Yeah. So in these schools where you're working, are you seeing much spread?
The answer is no. And so, part of this thing is we had to enter this not knowing what we were going to do. I mean, we really were wrestling, and the whole world was wrestling. The United States was wrestling.
Mhm.
University of Nebraska Medical also put out a guidance document. Harvard actually put one out almost the same week, actually, and they had very different thresholds. But the answer is we really didn't know. We had to say, and Ollie used his thresholds by looking at other countries. I think the Harvard guys took sort of mathematical modeling. But they were both actually, I said they both underbid what was safe actually. And that, well, we found out that masking was way more effective than we thought it was, for example. And so we weren't sure if you could have schools safely at levels of spread or 25 per 100,000. Turns out, yeah, we actually most of Nebraska, unfortunately, is in the 80 to 120 per 100,000. And it still seems to be okay. The thing we're trying to work through now is how do you monitor, at what point do you cross a threshold? That's my biggest worry right now within our school systems. The good news is it turned out, well, some of our school teachers just happened to be free over the summer and worked as contact tracers over the summer. So it turned out our school nurses were pretty good at contact tracing. And so doing a lot of work in their school system, put in a whole new tracking system for its own internal contact tracing. And they're running numbers based on kids and staff. And literally last week, we completed analysis where they looked at rates of spread in middle school versus elementary versus high school versus administrative, and then compared them to age-adjusted rates in the community. The good news is we found out that in most of our schools, it's no different. So it means that our interventions are working in school. And when kids and teachers are getting it, they're mostly getting it outside of school. We only had a few cases of, for example, you had a mask exempt kid who had, because of autism or whatever, couldn't wear a mask. There were some cases there. And then a few excess cases came from what I call the break room problem. And we see the exact thing in doctors and nurses. I'm sure you've seen it as well. In my day job where I work with clinics, 2 of our clinics had the same problem. A nurse, for example, got it from a spouse. And we're always good about keeping up our guard in front of the patients, but we sometimes lower our guard when we go relax in the break room. And that's where it was spreading in some of these schools, just like that's where it spread in some of our clinics as well. And you've probably seen that in your hospital system, that we lower our guard next to the people we're most comfortable with. So they're good in front of the kids, and just like we're good in front of the patients. And then that's the breakdown. And it happens over time. I mean, it's hard to be perfect for weeks and weeks and months and months. So.
Yeah, we're definitely seeing that. As far as I'm aware, we haven't had any staff get COVID from a COVID patient. It's been break room activities or, activities that they're getting into out of work.
I only know one pediatrician who probably did get it from a patient, but that's a little harder because one, they're not wearing the N95 and everything. It's just the typical surgical mask. And little kids are squirmy, yelling in your when you're trying to look in an ear.
Yeah. And if they're like my grandchildren, they want to pull the mask off your face.
Yep.
Yeah. Yeah. So if you do come in contact with somebody that has COVID, the new guidance by the CDC for the 10 days, I was listening to your YouTube talk, and, it could be 14 days that you get sick.
Yeah.
I mean,
it's an interesting, you had just got off a call where I had to try to explain to people that they're not said that you're magically okay at 10 days.
Right.
And I told them what you really need to think is there's what you can do and what you should do, and they're not always the same thing. So the CDC, you can get done with quarantine at 10 days. Doesn't mean you should, though. And so the example is, and it's all a degree of how comfortable are you. So at 14 days, 99% plus are positive by 14 days. 10 days, it's probably more like 95%. So again, it's one of those things, how good is it for you? If it's general low risk environment, maybe I think 10 days is okay. However, it's me exposing my father-in-law who's going to be high risk. I'm going to go 14 days. It's just because the CDC says you could stop at 10 doesn't mean you should stop at 10. And so in this situation, it's someone who's going to come to a meeting and it's like, this is a non-essential meeting. It's going to be quick, mostly formalities. It's not worth taking a 5% more risk just to be there when this isn't an important meeting. So yes, the CDC says you can, but I don't think that you should.
Okay. Yeah, it's the same with everything with the CDC. I feel like, they give us really great guidance, and it's up to you then to enhance it to what, it needs to be.
Yeah.
Oh, well,
And I don't think
mean,
it was explained very well to the general public, though, unfortunately. And
yeah, maybe.
I think some of our politicians also misread it as well, which is what adds to the problem. And so CDC essentially said, don't let perfect be the enemy of good. I'd rather have 80% of people following a 10-day quarantine than 15% following a 14-day. And that's where the numbers game comes in again.
Right. Yeah. So pretty much, you do your quarantine and you do a risk assessment, after 10 days, if, there's still that chance that you might get sick, and you're going to, like you say, see your elderly father, or, be around somebody who's vulnerable, then extend it a little bit longer.
Yeah. And I think it's really important to think, well, not of me, but of everybody else. I'm not too worried about me as a 51-year-old male with no health conditions. My risk is probably, 1 in 300, 1 in 500, somewhere in that range. So I'm not that worried about me. And if it was just my daughter is back from college, well, she's even lower risk because she's a young woman, which is like what the lowest risk you could be. So if it was just me and her, I wouldn't be so worried. But if it's me and my father-in-law or my mom and dad, totally different story. And so I think you realize who you're around, not just your own circumstances. And that's hard for people to realize sometimes. It's not all.
However, we've seen some healthy people get it pretty bad. So it's just one of those really strange things about this disease. I think we've still got an awful lot to learn about it.
Yeah.
Still.
Yeah. Well, it's kind of medicine for you.
Yes. So we've got masks, we've got social distancing, and then hand washing.
Yeah.
Yeah.
And there's some importance. I mean, I haven't seen the exact studies to say proportions, and maybe we'll never get the. I would guess that 90% is droplet spread, 9% is aerosol, and maybe 1% is fomite. But when we started, we didn't know that. I mean, it is like norovirus that just spreads through contact surfaces everywhere. And so people, I think, initially went way overboard. And there's a good podcast a while back called Hygiene Theater that people kind of overdid it. And sometimes it was mostly for show because people could see that where they couldn't see the other stuff. But it is still a risk, and still just wash your hands. You don't have to go sterilizing the groceries and all that kind of stuff. But hand washing, because certainly someone could cough onto my laptop. I could touch the laptop like on the podium yesterday. I want to use hand sanitizers because he was the one guy took his mask off at the podium, and I wasn't quite comfortable with that, but oh well. So you do what you can. So I do think, you do need to wash your hands, and of course, people always forget it works for everything else too. Influenza, coronavirus, strep. I mean, there's other reasons to wash it. So.
Right. We are in flu season. Yeah, I feel too, though, that I always feel like I've got to point out to people that you've got to wash your hands properly. You've got to get your fingertips for one thing. Your thumbs, your fingertips are usually left out. And it's your fingertips that you're using at the grocery store to punch in your password, to pay for things, or your at gas stations as well. Making sure that, you wash your hands before you touch these things, but also wash your hands after it, because the person before you probably didn't wash their hands before they touched it.
Yeah. I actually wonder if there may be some long-term benefits from this. People are getting into hands. There's sanitizer everywhere. I mean, everywhere there's another squirt bottle, which is a good thing. So, I mean, after this, I like to look for the silver linings, and that, well, maybe after this we'll have less spread of influenza, strep throat, and norovirus because people got in the habit of finally washing their hands like they should all along. So there could be some long-lasting cultural benefits to this.
I actually like the fact that in restaurants, I don't go and eat in restaurants, but I, get takeaway, and I'm glad to see that they're wearing masks because they're talking. And I know that before, when they were talking and there was no mask, there was probably some spit going in, accidentally, of course. Yeah. So I'm really happy to see them all wearing a mask. I'd like that to continue.
Well, I wonder if some other cultural things will change. My oldest daughter lives in Japan, and the Japanese have always worn masks whenever they're sick because it was, again, a concern for others. I don't want to expose people. So it was easy for them to convert to wearing masks really quickly, and there's no accident why their run numbers are some of the lowest in the world. And so they were really good about doing that, and so it's worked. And they also have a habit of not doing a hug and 2 air kisses, when they do a bow. Well, maybe there's a reason for that. Maybe it developed because of influenza over centuries. I don't know. Maybe an anthropologist to look into that. Yeah,
I suppose a bad place for like hugs, or at least I know the church that I go to, like part of the session is to hug everybody, shake hands and hug. And, thankfully we haven't been meeting since the beginning of COVID, but
Yeah.
I think that happens in a lot of churches.
Yeah. Well, maybe there's no accident. The first two bad outbreaks were in Italy and Spain, where they're all over each other.
Oh, yeah. Yeah. Very, very huggy. Yeah.
Yes.
I'm actually from Scotland, and I'm like, just look at me. That's enough of a hug for me. I don't need you to don't come close.
Yep.
But, yeah. And I guess the final piece of that then would be vaccination. And, we've got that coming. And I was reassured to hear you say that you're ready to get in line for it.
Yep. There's enough data for me to say yes already. Maybe it's not ready enough for the general public, but I think we're getting close to that. I think one thing, there's been some really good podcasts. There's a guy at ZDog who does this really good podcast, and he's an internist, but he has an alternate persona. Funny guy, but good explanation of the mRNA vaccine, how it works. And there's some things about the mRNA vaccine that might make it safer than other vaccines, and that the messenger RNA, the same thing that requires it to be refrigerated is because it's so unstable, and you want it to go away quickly, essentially. And messenger RNA is an inherently unstable thing, so it's not going to be in your body for very long. It just has to be in your body long enough to do what it needs to do.
Right.
And so the numbers are looking really good in terms of effectiveness. That 90 to 95% effective was way more than people were hoping, actually. And the one study from the Moderna had 30 hospitalizations and 1 death, and all 31 were in the non-vaccinated. And so we know that it's highly effective, which is a good thing. And it's been done, I think I read this morning, 37,000 interventions that have been given already. So we know out of 37,000, no adverse actions yet. So 1 out of 37,000 at least or better. That's starting to look really good. The downside is it does generate a pretty robust immune response, which means you may get a fever and a headache from just as your immune system's reacting so fast, which is kind of a good thing, but people need to understand that it's not necessarily a bad thing to get a fever after the vaccine. It means your immune system's working. So we'll have to educate people to understand that.
Yeah, we actually did a Zoom chat with a couple of people, and one of them was Sonia Bell, who was part of the phase 1 study, and very brave of her, if you ask me, to do that, young mother of kids. But yeah, she didn't have any long-term, she didn't have anything bad, and she was like, yeah, she would definitely do it again. So.
Yeah, and we've had and a good thing in Nebraska. We've had some politicians volunteer and even post on Facebook that they did get the vaccine. And one was Tony Vargas, who's a senator from Omaha, which is also important because we need to make sure we reach our minority populations, because some of them are they're not always given the same medical care as the rest of us. And in the past, they've not always done good studies, including both men and women and minorities. And they've done a good job with this vaccine of including both men and women and minorities. And they've already had some preliminary data on subgroups saying that both for minorities and men and women, it seems to be equally effective. Next, we need to know age. I think they've done a good job of trying to do the studies better than they've done in the past, where it used to be only done on white men. Well, we need to do it on women and non-white people too. And I think they've done a good job with that.
Yeah, and I think children are the ones that have been missed out so far, but they're probably going to start doing some on pediatrics.
Yeah. On the other hand, the risk for children, thankfully, is much
right.
So probably on the order of influenza, honestly. So whereas it's much higher. So I did see, I believe they were going to potentially okay it down to age 16, but getting more is going to require. We always have a higher threshold for experimenting on children than adults, so that's a good thing.
Great. Oh, well, Dr. Rauner, it's been a real pleasure talking to you, and keep up your good work with your YouTube videos. I'm definitely going to be subscribing and following, what you have to say in the future.
Good. All right.
So, do you have anything final to say about preventing the spread of this infection?
Probably not. I guess we covered a good chunk of what we need. We just need to be careful. We need to wear a mask. We need to avoid those situations. Understand the underlying things. Don't think 6 feet is a magic word, for example. Understand the why behind it. I think when people understand why, they're more likely to do it.
Yeah.
And partly it's just the hope. The good news is that we're literally within 3 to 6 months of stopping this thing. So there's light at the end of the tunnel. And I'm starting to look forward to the things we could do on the other end that would be good. After this, it has pulled enough people into public health that people are taking public health more seriously now. So that means it could be, although we've gone through something bad right now, it could be in the next 5 to 10 years, we have a healthier population because people are taking public health more seriously now.
Thank you, everybody, and or at least thank you, everybody, for listening, and thank you again, Dr. Rauner, for all your information.
All right, good.
It was a pleasure. Thank you.
Yeah, you too.
Goodbye.